Good morning to everyone and welcome to today's session. Medical and surgical nursing. This is one of the most crucial subject in the staff nurse exam preparation. Whether you take a public service commission of any state, PSC. In case of Tamil Nadu, we call it as MRB. In Telangana, we call Telangana Public Service Commission Staff Nurse Recruitment Exam. So the ultimate idea is how to revise all the 14 subjects in the nursing and crack the Staff Nurse Recruitment Exam, which is highly competitive, so that you will be able to score a top rank and get a government job. So this is Dr. Murali Bharadwaj, and I'm going to be with you until you get the job as a staff nurse. So let us make the great beginning. And every day morning, 10 a.m. to 1 p.m., we have a live online interactive session. It is absolutely free. You can tell all your fellow friends, brothers, sisters, everyone to join this staff nurse online coaching program. So let's make the great beginning. I will try to take up the questions, and with the help of the questions, I will try to discuss the concepts. That is the best way to prepare for the staff nurse recruitment exam. So let's make the great beginning in the medical and surgical nursing. Now, who is known as the father of medicine? This is more of a quizzical question, which you have to be very sure about. So the father of medicine is Hippocrates. And this great man, Hippocrates, did a lot of work in the ancient times when there is a outbreak of plague in Athens, in the Greece. So Hippocrates also founded the school of island of Kos, where the young people were taught medicine. And today, we as doctors are taking a Hippocratic oath at the time of taking our medical degree to practice in an ethical manner. So, who is our man? You should not forget. What is the word? Hippocrates. Hippocrates. So, Hippocrates is a man which you need to remember. With a salutation to this great man, let us start our preparation of medical and surgical nursing. Now, what is the commonest cause of the blindness in India? Is a favorite question of the examiner. So, there is a temptation to answer vitamin A deficiency. But if you take the overall percentage of the various causes, you should remember it is the cataract. The cataract is the most common cause for the blindness in India, percentage-wise. So if you take cataract, 62.6%, this is very important, 62.6% of people become blind because of the cataract. So what is cataract? The lens become completely opaque. You can't see through the lens. That is the whole problem of cataract. Refractive errors means short-sightedness, long-sightedness. Long-sightedness is called myopia. So you should remember the long-sightedness is called myopia. Myopic people cannot be able to see the things which are very far off. And what do you use to detect the amount of myopia? We use the Snellen's chart. Snellen's chart is the one which is used. Then a middle-aged man cannot be able to read the newspaper because he lost the accommodation in the eye. And what is that condition called as? It is called as presbyopia. Presbyopia is what you should remember. And myopia, presbyopia, these are all called refractive errors. They are the second most common cause of the blindness. So that is the reason it is so important to detect the cataract and bring vision to everybody. They say, Sarvendriyanam Nayanam Pradhanam. The eyes and the vision are the most important thing for any human being. So that is the reason the government also spends a lot of money to treat the cataract. Now, what is the most useful test for the detection of early renal dysfunction? The renal dysfunction in a very early phase, how can you be able to detect it? So you should remember it is the creatinine clearance, which you need to remember as the earliest way by which the renal dysfunction is identified. So how do we calculate creatinine clearance? So we take how much creatinine is there in the urine, that is in milligrams per deciliter, into total volume of the urine divided by how much creatinine is there in the serum, concentration of the creatinine in the serum, which is calculated as milligrams per deciliter into 1440 in the denominator. So typically, what is the creatinine clearance? Creatinine clearance is around 125 ml per minute. How much? 125 ml per minute. This is also a favorite question of the examiner in a lot of staff nurse exams, recruitment exams. And if there is any decrease of this creatinine clearance, it is a very sensitive indicator. What is meant by sensitive indicator? At a very early stage of the disease process, if you can detect it, you call it as sensitive indicator, very early stage. Then what is meant by specific indicator? Two words you should understand: specific indicator, sensitive indicator. What is the difference? Any test has two things. One is sensitivity, other is called specificity. So sensitivity is typically a feature which says how early a particular diagnostic test can detect. How early? If it can detect in a very early stage of disease, if the disease can be detected by using a diagnostic test, what is that called? Sensitive. Once more, aur ek baar mere saath bolo. Once more, you tell along with me. Sensitive is early. Specific means if this test is positive, then this diagnosis is positive. That is called specificity. So creatinine clearance is a very sensitive indicator of the glomerular filtration rate, is what you need to remember. Now, the normal mean pulmonary artery pressure is how much? You need to know what is the pulmonary artery pressure, because few people develop an entity, a condition called as pulmonary hypertension. It is called pulmonary hypertension. So that is the reason you need to know what defines pulmonary hypertension. But let us have an understanding as how is the circulation of the heart. If you know that, you can be able to answer this question. So I will take you for that. Yes, let's take the whiteboard. So let me draw the So let us say this is the heart. Heart has 4 chambers, you know very well. There is a right atrium and there is a right ventricle. Then there is a left atrium, very good, and there is a left ventricle. Agreed? This much you know already. You're already a cardiac nurse, right? Now, there is an aorta which comes from the left ventricle. And what enters into the left atrium? Here you have the lungs. From the lungs, the blood gets purified and it comes into the left atrium. So from the lungs into the left atrium, what do you call this? You call this as pulmonary vein. Generally we think vein means bad blood. No. pulmonary vein has good blood, oxygenated blood. Then what comes out of right ventricle? You have a pulmonary artery. So what will this pulmonary artery do? Does pulmonary artery become pulmonary capillaries? Pulmonary capillaries combined to form will typically flow into the lungs, and in the lungs they get oxygenated, and from the lungs this pulmonary vein comes and drains into left atrium. That's how the right ventricle, which has deoxygenated blood, that is, right side always has got impure blood, right? So deoxygenated blood which is there in the right ventricle, which came from throughout our body, right? So that passes into the pulmonary artery, goes into pulmonary capillaries, gets purified in the lung, and then it will come back to the left side of the heart. That is called the circulation. That is a typical circulation. Then who brings the impure blood into right ventricle? It is the right atrium which brings. From where the right atrium gets the blood? Let us talk about it. Right atrium get the blood from two sources. The impure blood which is coming from the head and upper part of the body, what is that called? Superior vena cava. And the impure blood which is coming, deoxygenated blood which is coming from the lower part of the body, what is that called as? Lower part of the body. That is called as inferior vena cava. So both of them bring the impure blood into right atrium, passes it into right ventricle, and from right ventricle they pass the blood into pulmonary artery. Keep telling along with me, then you will be able to remember. So from the pulmonary artery, the blood will pass into the lungs and it get purified. It forms pulmonary vein, and the pulmonary venous blood will come into the left atrium, and from the left atrium the blood passes into, this is all good blood, into left ventricle, and from the left ventricle it will go into aorta, and through the aorta it will go throughout our body. So once more you repeat, superior vena cava and inferior vena cava. They bring the blood to the right atrium, that goes into right ventricle, that goes into pulmonary artery, that goes into lungs, and that comes out as pulmonary vein, goes into left atrium. From there it goes into left ventricle. From there it gets distributed throughout the body through aorta. So we check the blood pressure, right? So where is this pressure? This is the pressure of the blood coming from the aorta and going into our hands. Here you have the radial artery, right? So you are checking the blood pressure in the radial artery. Indirectly you are checking the blood pressure in the aorta, and that way you are indirectly checking the pressure in the left ventricle, and this is called as systemic blood pressure, right? In that you have the pressure when the heart contracts. What is that called? Systolic blood pressure. When the heart relaxes, what is that pressure called as? Diastolic blood pressure is what you need to remember. Whereas in the pulmonary vessels, if you take, the pressure in the pulmonary artery is a reflection of the pressure in the right ventricle, the right side of the heart. That is what you need to remember. So now the examiner's question is, what is the pressure, mean pressure in the pulmonary artery is the examiner's question. So what is your answer, doc? So you should remember 10 to 20 millimeters of mercury. Just like you have 120 by 80, we call systolic and diastolic in the systemic circulation. That is when you are checking the radial artery. So 10 to 20 millimeters of mercury is the normal mean pressure. If this 20 millimeters of mercury up to 20 to 40 millimeters of mercury. If the pressure increases, mean pulmonary artery pressure increase, you call mild pulmonary hypertension. Just like systemic blood vessels have got, that is with the BP what you are checking, the systemic blood pressure, the way it has got a systolic and diastolic and a mean pressure, similarly pulmonary artery also has got a systolic, diastolic and a mean pulmonary arterial pressure. So that is what we are talking about. So 20 to 40 millimeters of mercury we call mild pulmonary hypertension. 40 to 60 millimeters of mercury we call moderate pulmonary hypertension. Moderate pulmonary hypertension is a favorite question of the examiner. In the tomorrow's exam, you may be going for RRB exam, or you may be going for the State Public Service Commission staff nurse recruitment exam, or NCLEX exam, or if you are going to Abu Dhabi or Middle East, you'll be taking HAAD exam, etc., etc. For any exam, fundamentals, basics are very important. Next 200 hours, I'm going to make you very strong by discussing about 8,000 MCQs and the concepts in all the 14 subjects which are often tested in the various nurse recruitment exams. So 120 by 80 is the systemic blood pressure. So 20 to 40 pulmonary artery pressure is called mild pulmonary artery pressure. 40 to 60 is called moderate pulmonary hypertension. And 60 to 80, anything above 60 is called as a severe pulmonary hypertension. If the pulmonary artery mean pressure is more than 60 millimeters of mercury, you call severe pulmonary hypertension. That is what you have to basically remember. So this is what we are exactly discussing, which you need to remember, that you have a right atrium going into right ventricle. From the right ventricle, the blood will go into pulmonary artery. Then from left atrium, the blood comes into left ventricle. From the left ventricle, the blood goes into the aorta, That's what you have to remember. So you have the pulmonary artery, the left and right pulmonary artery. Both the left and right pulmonary artery are opening into what? Into right ventricle. So we are talking about the pressure, the mean pressure in the pulmonary artery, you should remember, is up to 10 to 20 millimeters of mercury is what you are going to remember. Now, let's take up the next question. What should the nurse do first when a male client is having tonic-clonic seizures? So as a nurse, it is very common to find a lot of patients developing epilepsy, seizure. So what is a seizure? So you should remember that in our brain is like an electrical transformer. The electrical activity in the brain is organized electrical activity normally. If it become a disorganized electrical activity, all our muscles will start contracting simultaneously, and that is called generalized tonic-clonic seizure. Generalized tonic-clonic seizure. What is meant by tone? What is meant by tone? See, you have a muscle, right? So if you press the muscle, it is not easy, it is not very flabby, it is very tight, right? So that is called tone. Then when the seizure is happening, the muscles are going into an increased tone. And similarly, what is meant by clonus? Clonus is also a typical feature whenever the tone of the muscle happen to increase, hypertonicity occur. So that typically occurs at the time of the seizures. When all muscles are having it, you call it as what? Generalized tonic-clonic seizure. Now, we need to know how are we going to manage this condition. First thing that you need to remember is you need to restrain the client's arms and legs. You need to elevate the head of the bed. You need to put a tongue blade in the client's mouth so that he doesn't bite the tongue. And then you need to prevent the injury. But now the question is, of all these things, which is the first thing you want to do? Most important thing you need to do is you need to prevent injury. If the person falls down, from the bed because of the seizures, then he may end up in a fracture. So that is the reason prevention of injury is the first thing you need to do as a nurse, is what you should remember. So let us look into all these important things. First, do not try to stop the person's movements when he is having seizures. Then the time for which these seizures are happening is very important. If they are lasting longer than 5 minutes, or then you need to seek an emergency treatment. More than 5 minutes is too long. Then you move the objects in the surrounding area so that you are preventing the injury. You try to lay the person on the ground, on the floor, and gently turn him onto his side, onto one side. That is the next important thing. And you need to place something which is soft and flat under the head is very important. And you remove any items from the head and anything around the neck, because during the time of the seizure, if that happened to press upon his neck, that can lead to respiratory obstruction. So these are the important things which you should not forget. And don't put anything in the patient's mouth, very important. This is a very common misconception among the people, that put the ring, put the bangle, put a lot of things. No, that's not correct. Do not put anything in the person's mouth, otherwise he can aspirate it. Now, a very important condition, status epilepticus. What is the meaning of status epilepticus? Any seizure lasting more than 4 minutes, or if there are successive seizures without regaining the consciousness, that is the definition of status epilepticus. 4 minutes funda, you should not forget. Any seizure lasting longer than 4 minutes is considered to be status epilepticus. And what are the causes why people go into status epilepticus? Number one, suppose somebody is regularly taking epilepsy medicine. A lot of times they forget to take that. And that can precipitate a status epilepticus. Any infection, meningitis, encephalitis can be a predisposing factor. Any head trauma, if somebody had a head trauma, developed seizures that can last longer than 4 minutes. Any metabolic disorders, alcohol withdrawal, there are the various reasons. So the main things you need to remember about the management is maintain the airway, call the physician, notify the physician, administer oxygen, and if there is any IV medication that he is taking, phenytoin, phenobarbital, anything that he is already taking, you try to monitor the IV medication after the doctor prescribes. Now, post-ictally, when the patient had tonic-clonic seizures, what is meant by ictal? Let us be very sure on the terms. Ictus means one seizure is called ictus, one episode of seizure. After the seizure, especially generalized tonic-clonic seizures, patient will have confusion, he'll be running around, there can be bedwetting. So in that stage, how is a nurse going to manage? What are the principles? Number one, you observe the behavior of the patient in the post-ictal phase. A lot of times they are sleepy, they are confused, they are combative. They will try to hit the things and they have a difficulty in talking and they don't remember. That's called post-ictal amnesia. They are unable to remember. Then if they are sleepy, try to continue to put them in that side-lying position and protect their airway. Then you need to avoid injury. You need to give reassurance, reorienting. Hey Ramu, nothing will happen to you, don't worry, you're all right. That reorientation and the reassurance is needed. You need to assess, are there any injuries because of the epilepsy, because of that seizure. Then if you need to closely monitor, as a nurse, you need to closely monitor the post-ictal state. Number one, confusion can last for a few minutes. He may not be able to recognize anybody. He may not know whether it is a day, whether it's a night. So confusion can continue. Then sleepiness can continue for about few minutes to few hours. And nil per orally. Until the patient is unable to swallow, don't give him, otherwise he will aspirate. So nil orally is a very important thing until he is able to swallow properly. And you need to document the entire episode. These are the important things. Post-ictally, the nursing care need to be delivered. Then another important challenge is, if there is a tonic-clonic seizure in a person who is in wheelchair, what are you going to do as a nurse is very important question. So most important thing is, do not remove from the wheelchair unless it is very necessary, because he is already wheelchair bound. And you try to secure the wheelchair properly so that you can prevent him from falling down. You fasten the seat belt so that you prevent him falling down. You protect and support his head, very important. You ensure that he is breathing properly. And you need to put the pad in the wheelchair because the feet are touching that lower iron part. So you try to put a pad underneath to avoid the injury to the limbs. And you follow the seizure first aid protocol. This is the typical thing you need to do when there is a tonic-clonic seizure in the wheelchair. Now, the nerve fibers which carry impulses from the receptors to the central nervous system, what do you call them as? Very easy question about nomenclature. You basically call them as the afferents. So a little bit you need to know about the terminology. So this is the spinal cord. This is the spinal cord. And in the skin, you have the sensory receptors. From here, the sensation, suppose if I pinch you, if I happen to apply a pin and cause pain, pain is called nociception. What is the word used for pain? It's called nociception, right? So if there is any pain, if there is any touch is called as, what is the word used for touch sensation? We call it as proprioception. So proprioception, nociception, that is the pain. From the sensory receptors which are there in the skin, they get transmitted by the nerve which is called as the afferent nerve. Then if something is biting you or if you are getting pain, what will you do? Immediately you will withdraw the hand. So how do you withdraw the hand? Once the pain sensation comes to the spinal cord sends a nerve which is called a motor nerve that immediately will cause the contraction of the muscle and withdraw the limb away from that nociceptive stimulus. And this is called as the efferent nerve, is what you should basically remember. So whenever you should know a bit about neuromuscular junction. We are going to talk about something called neuromuscular junction. So whenever the nerve comes, the nerve brings a electrical activity in it that is called action potential. When the action potential comes, there are certain neurotransmitters, especially acetylcholine. Acetylcholine is the neurotransmitter. Tell me, what is this word? Acetylcholine is the neurotransmitter. It is staying inside these small bags. They are called vesicles. Vesicles. So from these vesicles, this neurotransmitter get released, acetylcholine. It will go and stimulate the movement of the ions, across the membrane. So this is the nerve and this is the muscle. This is the muscle. Hence, what is this called as? This is called neuromuscular junction. This is called as neuromuscular junction. Because this is the nerve, this is the muscle. So this then immediately when this calcium ions are moving, it will change the electrical potential of that membrane. Always you should remember, any membrane, there are positive ions on one side, negative ions on one side. And typically across the membrane there is something called membrane electrical potential. So this that membrane electrical potential created by the movement of this calcium ions is basically called depolarization. And this depolarization will make the muscle to contract. That is how a nerve brings the electrical signal, causes the release of the neurotransmitter, which is acetylcholine. That lead to the movement of the calcium across the membrane, and it will cause the depolarization of the membrane, and that makes the muscle to contract. This is called as the neuromuscular junction, right? So this is another way for you to remember. Always you should have a three-dimensional structure of the anatomy, physiology, biochemistry. You should have a imagination, a psychological imagination. Then only you will be able to understand the concepts very well. And always carry a pen and paper. Explain your classmates. Always teaching others is the best way that you can learn the concepts. So you have the axon, that is the nerve terminal, and the neurotransmitter is released. Here you have the synapse that is releasing the neurotransmitter, and that in turn is making the this is called as postsynaptic membrane. Postsynaptic membrane. And what is this called? This is called synapse. And what is this called? This area is called presynaptic membrane. Very good. And this is called as the nerve. So that makes the postsynaptic membrane to undergo what? Depolarization. Depolarization. And that makes the muscle to contract. Muscle to contract. That is what you should understand. So this is basically the cell body. And how does the electrical signal pass through the afferent nerve? It won't pass like our traffic. It will keep jumping. Like Spider-Man jumps from one roof to another roof. Like that, it will be jumping from one roof to another roof to another roof to another roof. And this is basically called myelin. What is this called? Myelin. So you have imagination of how the electrical wires, there is a copper, around that you are having that plastic. No? If you take an electrical wire, inside there is a copper, there is a outside plastic. So there is similar thing called myelin, which is surrounding this nerve fiber. And this myelin will be like nodes like this. And the purpose of the myelin is it will enable the electrical potential to jump from one node to the other node to the other node to the other node. And that is how the electricity can run faster, right? So that is the reason myelinated nerves. There are two types of nerves. Myelinated nerves, which have this kind of a sheath called myelin sheath. M-Y-E-L-I-N. Myelin. Myelin sheath is around the nerve. So you have two types of fibers called myelinated fibers, unmyelinated fibers. Two types of fibers that you need to know. So these unmyelinated and myelinated fibers, if you take the myelinated fibers, they conduct very fast from one node of Ranvier to another node of Ranvier. What is this called? Node of Ranvier. So this myelin will typically present around the nerve fiber, and it create what are called as nodes. What are those nodes called? Node of Ranvier. So from one node of Ranvier to another node of Ranvier, it will jump, and jumping is faster than crawling, right? So that is how the conduction of the electricity happen along the nerve fiber is what you should remember. So now you know, let us have a quick summary of what all that we studied. You know what is meant by afferent nerve, efferent nerve, what is neurosynaptic junction, what are action potentials, how does depolarization happen, how the muscle contraction happen, what is meant by a myelinated nerve, unmyelinated nerve, the node of Ranvier, etc., etc. Excellent. Now, the next question, anginal pain. Anginal pain typically occurs during activity or emotional stress. What is the type of the angina disease? So first of all, what is meant by angina? So let us study a bit about angina. So angina is fundamentally a chest pain. Why do we get chest pain? So if you take the heart, the muscle of the heart is called myocardium. Myocardium, very good. And it is supplied by coronary artery. Coronary artery is the one which is supplying the blood flow to the myocardium. So the muscle is working. When it is working, it requires oxygen. And how does the oxygen come? The coronary artery brings the oxygen. The blood in the coronary artery brings the oxygen. So suppose if the person is having a lot of lipid in his blood, lipid, fat, that fat accumulates inside the coronary and it decreases the blood flow. And when the blood flow to the heart decreases, right? Heart is after all a muscle. It's a pump. It's a muscle. So it leads to the development of the pain. And that is called as angina, is what you should remember. Then this angina, the quality of the pain is being divided into three types. What are the three types? One is called stable angina. Obviously the other type is called unstable angina. Unstable angina. The third is called fringe metal. Fringe metal. There is no metal inside it, but still it is called metal. Fringe metal angina. And this is also called, there is another name for it, which is called variant angina. So you should remember, fringe metal or variant angina is one variety. Unstable is another variety. Stable angina is another variety. Very simple. What are the differences between the three? You should know. First, you should know the definitions. What are the difference between the three of them? Why do they happen? We'll discuss about it. So, a anginal pain that happens during the activity or a emotional stress only, not at rest, only during emotional stress only, then you call it as stable angina. Now, what is meant by variant angina? What is the other name given for the variant angina? It is also called fringe metal. You always maintain one 200 pages notebook. So, first time it looks like a rocket science. but there is no rocket science. It's so easy. Only thing is you should understand the concepts, and you should try to apply all this knowledge on the patients. That's very important. And you should keep discussing with the doctors and the fellow colleagues and the concepts. Then the subject is very easy, right? Now, what is variant angina? Variant angina. Any temporary increase in a blood vessel is like a tube. It can undergo constriction, it can undergo dilatation. So if it constricts, that's called vasospasm. If it goes into vasospasm temporarily there is a decrease of the blood flow to the heart, and that is called variant angina. And typically the patients are young women with chest pain, temporary chest pain due to temporary vasospasm. What is that called? Variant or pringe-metal angina. Quite often these women also have other parts of the body has blood vessels, no? Not only heart. So the blood vessels going to the cranial vessels to the head. If there is any vasoconstriction, what do you get? You get migraine. Quite often these women also have migraine headaches. Then there is something called Raynaud's phenomena. What is Raynaud's phenomena? Typically these people, suddenly when there is any exposure to cold, their blood vessels will go into intense spasm, so they become pale. The hand become pale. So this phenomena is called Raynaud's phenomena. Quite often the people, these young women who have variant angina, they also have Raynaud's phenomena, and migraine headache is what you should remember. Now let us talk about the definition of various types of angina. What are the three types of angina I told you? Stable angina, unstable angina, and variant angina. You have to be very, very sure. So, stable angina, let's talk about it. Typically it is a chest pain when the heart muscle is not getting enough amount of oxygen-rich blood. It is a chest pain or a discomfort, especially when the person becomes emotional or whenever they are walking or exerting themselves. Unstable angina. Unstable angina is also called ischemic discomfort. Why it's called? Now you need to know some important terminology that will help you basically. Yeah. A little bit of the terminology. Yeah. So, what is meant by ischemia? Ischemia, any decreased blood flow, is called blood flow or blood supply. Blood supply to any organ. It can be liver, it can be heart, it can be lungs, it can be brain. That's called ischemia. Ischemia. Then, when the blood flow is low, then the oxygen supply is also low. Then the muscle become necrosed. That's also called necrosis. Necrosis means it will become dead, and that is called infarction. When the ischemia lead to necrosis, then that is called infarction. So ischemia means, we all very commonly use the word ischemic heart disease, ischemic heart disease. What is the meaning of that? That means there's a decreased blood flow to the heart. And when that leads to necrosis of the heart muscle, then you call it as infarction. So, before infarction occurs, what's happening? There's a decreased blood flow. So, suppose if the coronary artery, which is supplying the blood flow to the heart, it is having any occlusion because of a blood clot. A blood clot inside the vessel. What is the term used? It's called thrombus. What is thrombus? Thrombus is a blood clot inside the blood vessel. Inside the blood vessel. Then you should know a word called embolus. What is the meaning of embolus? If this thrombus dislodges from the blood vessel and it started floating and reached a faraway location, like a clot inside the heart chamber has flown to the spleen on the left side. So it has flown to the spleen, let us say, or it has flown to the liver, or it has flown to the lungs, then it has floated there and then it blocked another blood vessel. That is called embolus. Embolus is a floating thrombus. Thrombus is a blood clot inside the blood vessel. Ischemia is a decreased blood flow, and infarction is the necrosis of the muscle. The muscle is dead. That is called as the infarction. So this angina, called unstable angina, typically is called the pre-infarction angina. If you don't treat it, the person will end up in myocardial infarction. That means it is significantly blocking the blood vessels. So to call angina unstable, there are three criteria you should remember. Number one, if the angina is at rest, whereas stable angina occur only when you exert a lot or when you become very emotional. So if it is occurring at rest, and usually it lasts, if it is lasting more than 10 minutes, if the patient's chest pain, angina is lasting more than 10 minutes, these are the very important questions you should remember, examiner is going to ask you. And if it is very severe, you should ask the patient, is it like your regular chest pain? No, it is very severe, the patient told you. Then if it is a new onset, that means just 4 to 6 weeks, in the recent 4 to 6 weeks if it is started, and if it is a crescendo nature. What is meant by crescendo? Crescendo means if something is elevating, that's called crescendo. So if it is a crescendo in nature, it continued to get elevated, then you basically call it as unstable angina is what you should remember. Now, the next question. In the ECG, where do you see U wave? U wave is seen if the patient is having hypokalemia, decreased potassium levels. Okay, what is meant by the U wave? So first, you should know what are the waves in ECG. First, you have a wave this is called P wave. What is this called? P wave. Then you have QRS complex. Any positive wave is called R wave, and any negative wave, you call it as before R wave is called Q wave. Any negative wave after the R wave is called S wave. Then after that you have a T wave. So after that you have a T wave. This is the T wave. And any wave after the T wave you call U wave. It can be positive wave or a negative wave. Doesn't matter. Any wave happening after the T wave is called U wave. So when do you get this U wave? You get the U wave if the person is having hypokalemia, that is decreased potassium. So you should know a little bit about the potassium serum levels. Serum potassium. What is the normal value? You should be very sure on these terms. 3.5 to 4.5 milliequivalents per liter. Serum sodium. What is the normal value? Commonly asked in exam. 135 to 145 milliequivalents per liter. So any serum potassium level, if it is less than 3, you call it as hypokalemia. Any serum sodium level less than 130, you call hyponatremia. So whenever you have a low potassium, then the patient typically develops certain ECG changes. So you should know what are those ECG changes. So for now, let us learn. U wave is a feature of hypokalemia. U wave is a wave that comes after the T wave. Now, let us say you have T wave. After that, you have U wave. Imagine a camel. Imagine a camel. You know how to draw a camel, right? Imagine a camel. This is called, a camel has a hump. There are 2 humps. What is this sign called? Double hump sign. Double hump. Double camel hump sign. When do you get it? Whenever there is any T wave, following that one more wave which is called U wave, then that is called the double humped camel sign in hypokalemia. So you can remember, this is the QRS complex, and here you have the T wave. In this case, T wave is inverted. T wave is inverted. And after T, any wave is called U wave. U is not a negative wave always. It can be positive wave. So T wave followed by U wave. One more example. This is the T wave and this is the U wave. Where do you get U wave? U wave, you get it in hypokalemia is what you have to remember. So there are various causes for U wave, not only hypokalemia. Hypokalemia is one cause, you remember. When the serum magnesium level is low, you get U wave. When the serum calcium level is low, you get U wave. When the temperature is very low, hypothermia, you get U wave. And if there is any enlarged heart, if the left ventricle is hypertrophic, you get U wave. And certain medicines, digoxin, can lead to U wave after the T wave in the ECG. And any raised intracranial pressure, if the person had a head injury, if there is a raised intracranial inside the skull, if the pressure increased, that also can lead to the U wave. The causes of the U waves is the favorite question of the examiner. Now, with this, we will take a break, and you are learning the concepts and you need to apply those concepts. There are totally 8,000 MCQs in the 14 subjects in nursing: fundamentals of nursing, medical surgical nursing, anatomy, physiology, biochemistry, microbiology, and nursing administration, nursing management, nursing informatics. So all these 14 subjects, slowly we will do a revision. This is a live online class, and every day morning 10 a.m. to 1 p.m. just log into our YouTube channel. You have a free broadcast, live online interactive broadcast, and it is going to help you a lot to prepare for all the staff nurse exams, international nursing exams like HAAD and NCLEX, etc., etc. Good luck, and see you once more tomorrow morning.